I can't believe it's been 4 years since I last interviewed today's guest. I wanted to have him come back because his non-clinical career has flourished since he was here before, and he's in a leadership position now of a large hospital system, which is awesome. So I think he has a lot to share with you all today. So with that, let me welcome back Dr. Nilesh Dave. Hello.
Hi, John. It's great to be back. Looking forward to chatting with you over what's been going on over the last 4 years and hoping that any of your listeners out there will hopefully get some nuggets of information and hopefully that'll help them get to similar or whatever pathway they're on.
No, I think it's going to help a lot, and I have a lot of questions. But when we last spoke in July of 2019, I think it's okay. I can mention you were basically working for one of the regional Blue Cross Blue Shield companies, and but you're no longer there, obviously. That's why I wanted to have you come back. You've made a couple of different changes, and you've also done some other things in between. So why don't you tell us what happened after why you decided to move on, and what the next job that you did was that would utilize all of your skills and education.
Yeah, sure. Happy to. Well, when I was working for that one of the subsidiaries of Blue Cross Blue Shield, I was outreached by another insurer to join their team, and the resources there that they had in analytics and the opportunity to get involved with more business innovation in that space, as well as population health, um, was too hard to pass up, and so I literally had to just drive down the street for that. When I took that position, and learned a ton. I'm great. I was never someone who actually liked the utilization management component, and this was a minimal part of the entire role. A lot of a lot of jobs in the non-clinical world will sort of describe themselves as working across a matrix or working across silos, so to speak. And I have to say that doing that transition to the other insurer ended up really teaching me some of those skills that it's not anybody that is above or below you in sort of an hierarchy. It's another department and group, but you've got a um, uh, common client or something like that, and that's what sort of brings you together in achieving some of the business objectives. And when I was there, you know, COVID was starting up, and so I was enjoying that role, and I thought, you know what, I want to maintain my clinical skills, and so I signed up to do some tele ICU moonlighting shifts. With being in a corporate position and having regular hours, it was not difficult to find time to do a clinical shift, and so
Right.
I started doing that, and it was different. So it kind of checked off the box of, yeah, it's critical care, and I'm an intensivist by training, and but it was in a different way. It was tele ICU, so I wanted to learn more about that because things were shifting towards telehealth,
Mm.
and certainly COVID accelerated that and made telehealth a more accepted way to also deliver healthcare. And so I um, I just expanded my sort of skill and exposure to it and signed up. And then out of, I guess, serendipity is what happened next, because I ended up being asked to oversee that multi-state tele-ICU operation.
Mm.
Um, and I almost, did a double take when I was asked that because this was an opportunity that aligned my clinical skills. I'd gotten a business degree before. I was in charge of quality metrics and policies for the health system that this was a part of, and so that had some inroads to my master's in public health I did in between medical school years, and and so it just seemed like this makes complete sense. Like, why not do something like this that you can get all these skill sets in under one roof?
That's impressive in a way, but it also, it's, what was the old saying that, what is good luck? It's like the combination of preparedness and opportunity. So,
Hmm.
unless you're open to it and you're prepared, however that preparation, occurred, you just never know when you take a new position or volunteer somewhere or whatever, what opportunities might show up. So what were you doing there? Just to kind of clarify, I was going to ask you about the location, but it sounds like you did not have to move to take on this new role. You said it was right down
No,
the street.
in fact, the company's headquarters moved from Boston to Dallas, and so their operations for their tele-ICU was also located literally within a block of the other two jobs I had previously. I mean, it was just sort of a
Wow.
business park, I guess, and that's why. But I didn't have to drive really anywhere else
You
to
know,
do.
another serendipitous thing in the sense that there's a lot of movement out of many states, but Texas is one where there's a lot of movement in, and that includes corporations as
For
well as
sure.
people, right?
That's for sure. Yep. Yep.
You've selected a good place to live and you know grow in your career. So that's another thing to keep in mind, I guess. Tell us again now, toward at the beginning, before you were doing the moonlighting, before you were heading down this telemedicine service, I guess. What were the actual duties that you were doing that were different, from what you had been doing earlier in your career?
So at both sort of insurance positions, there was a new program that both insurers had started in terms of a white glove kind of population health management
Hmm.
um, service for employers, employees, or members of the insurance, and
Mm-hmm.
looking at cost of care, drivers of care, managing and understanding the population of workers, and in really, using your medical knowledge and understanding, like, okay, you've got diabetes, which is a risk factor for coronary disease, and the folks that work in the different divisions of this company and the company had 400,000 people in the Blue Cross Blue Shield subsidiary that I was overseeing. And so that was a lot of that population health more so. But when I moved to the other insurer, there was more sort of KPIs, key performance indicator, um, and data associated with that we focused on as we were managing. I was managing three different companies with very disparate populations and risk factors.
Mm-hmm.
And so um, I had one that, employees would be in remote locations building solar farms, wind farms, and stadiums, and another that was building nuclear subs, and a third in drug development, and these are all employees with different uh, kinds of health problems, and some very similar. And but in that second role, there was a lot more of a business focus, a lot more strategy, uh,
Mm-hmm.
data driven analytics, and the opportunity to use that data capability that the company had to think of innovative approaches to some of those problems. And so that's where that when I pivoted away from the Blue Cross Blue Shield position, that's what I got out of that second job. And I think that, in retrospect, I think that set me up pretty well for when I, sort of started doing the tele ICU operations across multiple states. I mean, we had the same kind of setup. We had a lot of analytics. We were in charge of quality and metrics. We had key performance indicators that we had to meet. The usual ventilator length of stay, ICU length of stay, mortality. That's in the medical clinical world. That's what when you're in these sort of hybrid clinical business positions, a lot of those things are what you're looking at. Um, and so, being able to be in that tele-ICU position really solidified that. And I was able to leverage then my clinical knowledge as well, knowing what does it take to take care of an ICU patient and translate that into the business side for a health system.
That's what I think is great about physicians that move into these more executive positions is that they do have that understanding of the relationship with the patient, the needs of patients, medical terms, and all that. And if you can just kind of add the business side of it, to me, it's an ideal situation. I think, the companies you've worked for, I mean, they've recognized that they have CMOs and they have physicians in pretty high leadership positions, unlike a lot of hospitals. I mean, some large hospitals do, but there are a lot of hospitals out there that the first thing they did when the pandemic hit was get rid of their CMO because it was an
Mm-hmm.
expensive position, at least from what I've heard. So I don't know. That's why I think physicians sometimes get frustrated working in a health system, but I think you still have to fight for that. And if your colleagues that are at the hospital recognize that, they can hopefully encourage the leadership of the hospital to get more physician leaders like yourself. Okay, so tell us the next steps. Anything else you want to tell us about that position you were just describing? I know then after what 2 or 3 years, then you found something new to pursue.
Yeah, the so I there are a few variables that sort of were in the mix that the health system where I was doing the tele ICU um, had some struggles and things that were financially related, and so some of the tele ICU program was being contracted, and expansion was being halted, and being able to grow in that position, it was pretty clear it was going to be delayed for several years.
Mm,
And and so a lot of the planning and things that we had at the beginning of when I took it, a few years later, that was all sort of, cut. And so at that point, an opportunity at a Texas, Dallas based health system, the largest one, by footprint in terms of hospitals and things, was advertising a clinical effectiveness chief medical officer position. And so I threw my hat in the ring. And, one of the, and obviously after, rounds of interviews and things, they offered me the position. One of the things that, you know, my background is a divergent one. When you look at, I'm at a system level. We have a system CMO. In some ways, you could say I'm an associate system CMO, but they carved out a different CMO role with different parameters. And my background does not fit the hey, I've been in a hospital CMO for years, and now I'm transitioning to a system level. I mean, I was at a system level with the tele ICU, and in some ways, I was the critical care, subject matter expert overseeing our tele ICU operations and quality, and meeting all those metrics. So in some ways, there was some similarity to that CMO role, but I did not follow a traditional pathway. And in fact, I think I was very fortunate to be in a company now that actually appreciated my payer experience and my telehealth experience, which they've never had that background, and they thought that that would be an advantage for them based on the personnel and skill sets that they had, um, which was a nice, refreshing thing to hear.
Did
You
you,
know,
when you were looking at the job title, I guess if they posted it as such, clinical effectiveness CMO, I mean, I guess they could have said chief clinical effectiveness medical officer or something else, but I have not actually, I mean, I've heard the term clinical effectiveness, but I've never heard that applied to a CMO. So what were you thinking when you first looked at that?
well, I figured that there were probably service lines or clinical clinical service lines that, between hospitals, they were probably performing at different levels. And I'm sure I expected that there would probably be similar sized hospitals with similar availability of specialties, but their quality metrics um, were not predictably the same. And so we're sort of trying to figure out, well, what's driving that? And it turned out that thinking before learning more about the position was a new one that they had. It wasn't one that they had established years
Hmm.
ago. It was one that um, they got rid of one position and sort of reformatted it. And so for them, it was also a new thing. Um, and it was not only clinical effectiveness from the way you would think in the service line area, but also um, uh, sort of risk management, safety, credentialing, medical staff affairs. I'm also involved um, in deploying our telehealth strategy. I'm on their AI governance task force, which the ICU and just I've always been into the tech stuff. And so, with AI, generative AI and things, really versioning and so many platforms and vendors out there trying to, get a piece of the pie. We had to create a governance structure, and I helped create a framework and took some time to um, take a certification course from MIT on AI in healthcare as a way to just complement that because I knew some, but not I didn't think I knew enough. And so I just did that on my own, while in the role, taking classes and things online, and learning that stuff. And so, I once I saw some of these other aspects of clinical effectiveness, and it really is just making the clinical engine run as smoothly as it can. Um, that's what it kind of boils down to now, and um, it's been a phenomenal experience.
David describes some of the things that you do in that role that are more leadership management and so forth. I think it's difficult sometimes for physicians to understand like what it's like to move from that strictly clinical, even if you're the head of a service line or something, to working at the level of, let's say, a senior VP, chief medical officer. But it's going to be different for every system as well. You move from one to another. So, what does it look like for your system? Like, who are your peers? Do you meet which other senior leaders do you regularly meet with or report to for that matter? It'd be interesting to hear how that's structured.
Yeah, so interesting. So I'll add one other point is that, when I was in the ICU position, I had 40, 50 nurses, and probably this equivalent number of physicians on our internal ICU operations. So I had a whole team, I had administrative folks helping to run the operations, a nursing counterpart, um, and a few other internal business partners. When I joined my current role, the directive was to get things done working through the business. So other than an administrative assistant who's fantastic, I do not have 100-person team under me or any of that. So that's one big difference that I have already in the job, which was a bit strange to me based on the projects and things. But I came to learn through listening to interviews like this that there are many folks who are in these sort of officer positions that work through the business and get things done. And so on a day-to-day basis, the folks that I interact with could be other VPs who oversee our hospital channel, for example. We have all our hospitals in a channel. We have an ambulatory channel and a telehealth channel. And so we have VPs that oversee that and a lot of them are non-clinical business
Mhm.
trained background. Um, and so I work a lot with them on different aspects of my projects. I even will directly collaborate with the COO of the company, and occasionally with the CEO and CFO, as
Mhm.
well as the strategy officer. So it's not a completely sort of flat organization in that sense, but the opportunities are there, um, and at times necessary. So I've had, and I also work with the chief medical officers of each hospital.
Hmm.
They don't all report to me. There's sort of a dotted line,
Right.
myself and my colleague, and so we collaborate together with them. We work with the chief nursing officers, hospital presidents, or sort of in the business channel, but we work with those executives at the local hospital levels, and then their sort of system um, counterparts, who are maybe senior VPs or executive VPs or whatever. So it's all across the board. I work closely with the VP of Care Transition Management, who oversees all of the folks in the hospitals, and so it really is a potpourri of various officers, and even and at all levels. It's not just officers. I mean,
Hmm.
I
Yeah.
with
When I
your
was working at CMO, of course, it was a hospital, so it was very contained. And but we just say that was matrix relationship. So we knew that if we had something we had to get done, it wasn't that I had to go through another VP or directly to their, I would just deal with whoever I had to deal with to get it done.
Mhm.
And then hopefully we were all on the same page, had sort of the same strategic plan and management plan that we were working on. And so, at that level, you even have to learn how to give up a little bit of something you have to make someone else's, thing work because it's for the overall improvement of the organization, not your own little fiefdom within it. So that sounds
That's
really
right.
good. The other thing that it makes me think about is when, going through some of the courses at the APL and, and what I've taught, when I've heard from others doing MBAs and so forth, the importance of things like negotiation, communication, persuasion, even as a thing. And it's all about doing that rather than, there's no such thing really anymore, I think, for the most part, of just saying, okay, I'm the boss, so I'm going to tell you what you're going to do, you know?
Well, and I think that's a great point, because one of the things you had mentioned, that a lot of times, folks in the with these opportunities sometimes struggle, and in sort of in reflection, I think there's a struggle. Part of the struggle comes from, just the language. You know,
Yeah.
a lot of us who may be, doing day-to-day clinical practice and maybe are involved in some greater hospital initiatives, or maybe it's the health systems doing, you're a cardiologist and there's some cardiovascular service line initiative and you're doing some of that. But being able to sort of translate that into, sort of business speak. And in fact, when I had to do my resume as I was pivoting into the non-clinical world, I think on our last discussion, I had mentioned that it took me a while to understand how to convert. Hey, I set up a system-wide inpatient hospice program. Well, there's another way of saying that, you know, on a resume that resonates with the non-clinical business executives that you might end up working with. And to your point about, um, you know, getting allies and strategizing, and it's a lot easier when you have that one patient in that one room and you're talking with different consultants, and there's sort of a you're for one consultant or for a combo, your hand is forced because of the clinical scenario situation and in the direction it is going in, and so you have no choice but to agree and just take care of it. Um, on this side, that is going on, but you're doing things system wide that aren't directly related to that patient and related to operations or strategy. And a lot of that maneuvering, um, change management, negotiating, let me do a solid favor for them now, and hopefully that'll be repaid when I'm in dire need of something as well. And I'm not keeping a little notebook of what I've done, but the people you work with, you kind of know, they'll remember, and
Yeah.
and sometimes you have to bring it up. But
Yeah.
that's a different skill set that, yeah, I had to learn a lot of it. I wasn't like, one of those. schmoozers who could easily,
Right.
just do that kind of thing naturally. I mean, that's not always the kind of people who can get things done in these roles. I mean, there are skills to learn.
Yeah. Yeah. And even, if you have a culture where that's the way things are done, it helps, but there's always individual personalities, and some people are more forthcoming. I remember I had a director that reported to me, and I loved her dearly, but she made me crazy because if somebody didn't do something they promised, like within a week and it was done, she would be like, it's not my problem. They said they were going to do it. It's like, no, you can't. You have to take responsibility beyond yourself and enable those other people to do what they are supposed to do without being, so black and white. So I mean, that's just another example. I'm glad you're here because I did have one or two other things I wanted to ask your opinion on because you have some experience with these things. And for example, you did that MPH back, I think, while you were in med school or between years or whatever. You did get an MBA and yeah, at Kellogg too, I think it was. So I mean, it's
Mhm.
not a community college MBA, you know, and you've done other things. I don't know if you've ever, been a member of the APL. I'm just wondering your opinion on all of those things, whether there's a prioritization if someone hasn't done any of them, or what your advice is on deciding on an MBA, deciding on doing an MPH, or doing some other things. I think, like you said, that you got some additional training in telemedicine and AI and that kind of thing.
Yeah, so I funny enough, when I was in med school, my desire was to be in infectious diseases.
Hmm.
And at the time, I wanted to learn more about epidemiology, biostats,
Mm-hmm.
and health outcomes. At the time, that was the buzzword.
Right.
And when I did mine at Johns Hopkins, they had a program with all that, and it was just a 1 year program. I didn't go into infectious disease, you know, but I did learn some skills, especially with the epidemiology and the biostats, that from a data analytics perspective, which I would not have predicted back then,
Mm-hmm.
ended up helping me out. So I pursued that because in the moment it made sense for what I was trying to do. The business degree, I always hear, and I've been asked, and I also hear the question of, well, I want to do something non-clinical, so I better go ahead and get my MBA because that's, like a lot of our physician pathway, we've got to get a medical degree, or a doctor of osteopathic medicine degree or something, and be able to be that doctor. But here, an MBA is not mandatory. There is that the American College of Physician, or I forget, healthcare executives or something,
Mm-hmm.
the ACHE or something.
Yes, that's the
Um,
one that's more for the hospital. Yeah, ACH.
yeah, so I mean, there's MBA like program you can go through there. I did it because I knew I lacked the ability, and when I was doing system-wide stuff as a practicing intensivist, getting involved in some of the health system initiatives, I was having a hard time trying to communicate effectively with non-clinical business leaders. And if anything, I felt like I was just oversimplifying things. And as I listened closely in meetings, I saw that there was a gap. And so I did that. But I did not, at the time, was not doing it hoping that it's going to open, 1,000 doors of opportunities. That did not open really any doors right away, even
Mm-hmm.
with an alumni network that was strong and all of that. I mean, it's just that, that was not something that was automatic. You still have to hustle and try to find those opportunities and hope that one thing builds on another and sort of strategize like that. Um, and those skills, ultimately will come in handy, and they have for me now. Um, but I think it's a false way of thinking if getting an additional degree is the gateway to doing things like this. There are plenty of folks that I know that don't have a public health degree or an MBA or master's in health administration, or any of those, that are fantastic leaders. and whether they've done work on the side to learn that stuff, possible. I don't
Mhm.
know, but but it's not necessary.
So what I'm hearing, it was like the MPH. There was a reason at the time that you did that, and then with the
Hmm.
MBA, you were already kind of facing, understanding. I don't know, maybe budgets, maybe financial statements. You had the people you were talking to at that time, and you thought, okay, this is going to help me to address that need. Okay.
Yep, and I was also at the time thinking a little bit entrepreneurial that maybe I'll sort of do something different on my own, and I wanted some of that background, and I thought about should I go and pursue a healthcare related MBA or not, and I actually decided conscientiously to not do a healthcare one. I wanted to meet people from all kinds of industries because my background is divergent. My thinking is divergent and more on, I like to cross pollinate with folks in other industries to just, to be a better have a better innovation mindset. And so I looked at it that way and chose a program,
Yeah.
with that.
That makes sense, because I do hear the same thing. Maybe I don't know what I want to do. I want to get out of medicine, so I'm going to get an MBA. And it's like, well, that's not really, it's a little bit of a shotgun approach in the sense that it doesn't really give you any particular direction. And
Right.
and I think employers too. I mean, if you're going to be working for someone like a big system or insurance company or pharma, they're going to look at that like and say, well, it doesn't really fit, any kind of logical step in your career. You just decided one day to get an MBA while you're practicing full time in, family medicine or something. But I mean, I'm sure those things long term can benefit in unknown ways as well. But it's a lot of time and money to invest without having necessarily a direction that you're shooting for.
I will wanted to add, especially, for the benefit of the listeners, is that, when I took on this role, um, I and even when I was in my previous role, I had started to work with an executive coach.
Hmm.
And, at first I was like, well, I don't know, do I really need that? I mean, we're all smart and savvy enough. I mean, maybe we can figure this out. But no, emotional intelligence is probably the number one most valuable skill and capability that you need to grow and mature when you're in these types of positions. And there's frameworks of how to manage workloads and how to have those conversations, the negotiating, the talking with different folks and trying to not only get your the stuff on your table moved forward, but a collaborative project as well. And there's skills there that not necessarily soft skills, but there are some hard skills as well that for me, to sort of, and it was something that I thought would play into the brand that I wanted for myself. What do I
Mm-hmm.
want to be known for? And how do I want to execute on that? Uh, an executive coach was something that continues to make sense. And, I'm been working with the same person now on a second year, um, monthly. Before it was more frequently, especially when I was onboarding in this new role
Yeah.
at the end of April. So I throw that out there just because not everything's in the books. I mean, you
Yeah.
do need it. You do need sometimes some coaching. And will there be a time where I won't need it? I'm not sure. It just depends.
Yeah, I mean, it's just you can't really, unless you've had a coach like that, you really can't imagine the amount of wisdom that you can get from a coach. And
Yeah,
they're kind of like a therapist in a way. They don't just tell you what to do, right? They get you to generate the aha moments and just help you to clarify your thinking and everything gets the bottom line is it doesn't make you a better person. It just everything you would have maybe eventually learned, I think, just happens faster when you're in that situation.
I agree. And sometimes in the chaos, they can help tell you, yeah, that's not the way for your role, what it is. You should be, really having this resource or support, or you should really be looking at things this way, or you're now in a position that's different than what you did before. So you got to start sort of shifting, the way you to have executive presence or to to do those things, which are skills to get success.
No, it's a really good point because, we only know, we know how we feel and our internal,
Hmm.
talking to ourselves. When you have this, someone who's objective and really has no vested interest other than in your success, it's just a different perspective that just really can open your eyes. Um, it reminds me too of something that one of my friends, colleagues, advised me, and he was a hospital leader way before I was, and he said when the next time when you apply for a job at one of these hospital systems or something, you should ask them to provide you with a business or leadership coach as part of your contract. I thought that was a brilliant idea. I never had the chance to implement that, but I thought that is a really good idea.
Yeah, and I agree. I had been told that after sort of a year into the job that my company also provides that,
Okay,
you know,
nice.
and I was like, whoa, really? You guys actually provide that kind of stuff? And I'm very blessed to be in a company that really invests in their own people, with innovation programs to for officers and things like that to really understand the business. That was one of the other things that I went through as I was learning the company. They're like, well, we're going to throw you in this program for 7 weeks. And I heard from all the strategy leaders, finance leaders, and it kind of fast tracked me in my education of just knowing where am I working at, what have been their goals, where are they trying to get to, and how do I fit into that? And that's just investing in their people. Not every company does that kind of thing.
Yeah, that's awesome. It really is. I think outside of medicine, it's very common for large businesses to
Hmm.
invest in coaches for their CEOs and senior leadership team and even managers sometimes. We're a little bit over time here, but I do want to ask you any thoughts about AI and medicine? It sounded like you have some experience, and is it something we can ignore for a while, or do we have to really start to learn about AI if we want to get into clinical or non-clinical future jobs?
Yeah, I've been involved in a lot of different um, in my own current job and just reading and talking to different folks in the AI space and I think that some of the takeaways that I would say to answer your question is one, I think the physicians and the healthcare teams that learn to work with AI as a tool um, are gonna do better than those who say, well, I'm not getting into this, or maybe reject the idea or think that it's a fad and eventually it'll go away. I don't think it's gonna go away. But with that said, the most important thing is understanding how do you evaluate a proper AI partner for your clinical operations? How is that AI, what they're calling AI, why are they calling it AI? How do they develop it? How do they test it? How is it biased? What's the risk that it can create harm? Um, and that's a lot of the governance sort of points that we set up. So for anyone working in the hospital side, if you don't have, or if your health system or your independent hospital doesn't have a governance structure, you need that. Secondly, you need a framework to kind of evaluate, all the different vendors and folks that are going to come at you with, hey, we've got this cool thing, and you never know, it could be half baked, and they're just looking for a partner to use data to sort of test it and sort of
Hmm.
iterate on it. Well, do you want to be that partner, or do you want to wait till it's baked more? You
Mhm.
know, but I think overall it's going to be a very helpful tool. We're using it, we're piloting it in our outpatient clinics, especially generative AI. Um, there are ambient AI programs that can listen to, in a HIPAA secure fashion, physician patient interactions and create a SOAP note
Mm.
or an APSO note, and then you can edit that and clean it up a little bit, but it's screened by a human and then sent to you very quickly. So you can just focus on talking to the patient and not even need a scribe. We have it being used in imaging, um, some of our business side, like revenue cycle. And so we're looking at that, even looking at programs that will evaluate when patients call a hospital and have a conversation, what's the tonality and what is that doing from a business side? What's the engagement? What are they mad at?
Mm,
What are they telling us that we may not have picked up on because it's otherwise done manually? So there's some cost savings potentially there, but all of these you want to have a governance structure to work through, um, because data security is also a very important thing.
mhm.
But yeah, it you should get on to the bandwagon, but carefully
I
with
see.
structure, with a framework, and and see where it can help you the most. I think all these burdensome and cumbersome tasks that have led that have been attributed to burnout, there's an opportunity here to reduce some of that note, doing all your notes at the end of the day and all that stuff.
Hmm.
You know, um,
All
there are
right.
tools out there that are good.
Yeah. Okay. Good to know. So we need to embrace it at some point, and but also to make sure there are ways to monitor it and make sure it's safe and it's secure and you're not being used as a and someone who's still working out the bugs in their AI systems.
Correct. Absolutely.
Well, I really thank you for being here today. This has been very, to me, I hope the listeners get the same that I got out of it. It's just very interesting and it's inspiring, and it's also a lot of good points to think about and remember as maybe we're pursuing, if my listeners are pursuing a career in, hospital management or any kind of management or leadership position. I know that we'll probably have some questions for you, so I think LinkedIn would probably be the simplest way for
Yep.
people to reach out. um, I know they can just look up Nilesh B. Dave and they're going to find you.
Yep.
I did notice on your LinkedIn profile it was ICU Doc was you, so you could try that too. But uh, if you do have a question, those of you at home listening, then I think Nilesh can help you out. But
I'm
I think
happy
you've given
to.
us a lot of things to think about. So this has been really good. I'm gonna have to catch up with you again in a few years. Maybe I'll have you come back, you and maybe a panel on AI. Again, I'm just afraid it's gonna become overwhelming very quickly.
It's yeah, it's just growing so fast. It's crazy. I mean, we can't keep up with it on our side.
Yeah, I can imagine. I mean, there's so many things coming at you every day. All right. Well, thank you very much for being here, and hopefully we'll get a chance to talk in the near future. And with that, I'll say goodbye.
Yep. Thank you very much for having me, and happy holidays and happy New Year to you.
Thank you. Okay,
Yep.
don't hang up. All right, excellent. This is great. Sorry, I kept you a little longer than I normally
No,
do.
it's okay. I have
This
the
is
time.
good. Fantastic. I really enjoyed it. You get people, I was going to ask you, like whether you get people, like to look at you as a mentor, that's kind of, I was going to frame the question, like advice, but I know that it helped me a lot just to have one or two mentors over the years. It just threw me a bone every quarter about which direction I should go. So I don't know if you had mentors along the way, but
I had a couple that I would reach out to and just sort of check in with them and tell them, this is what I'm thinking about, um, and have that conversation. A few were non-clinical hospital leaders
mm,
that just had just a great perspective on things. Others were folks who had um, walked a similar path,
mhm.
but had their own sort of uniqueness to it. And the more people talk to each other, the more open your mind becomes and these ideas and things, and you realize that there is not one pathway to get to these kinds of roles and positions. It's as long as it makes sense to you as you're taking the steps, it's that's sort of in the immediate. But to look so far ahead and say, well, I want to be, you know, a CMO at that place. Well,
I
yeah,
know.
I don't know if that's going to be an easy target or not, but you
I know
know.
I get impressed every once in a while. I run into someone who's like in their second year, or maybe they're even a resident, and they tell me like what they've got planned for the next 15 years. And like, I never thought that far ahead, to actually plan it out. I guess it could be a good thing, but you're right. Probably things are going to change along the way, but it's okay to have a goal, right?
You know, the sort of subgroup now that I've become very intrigued with, although I haven't talked to very many of them, not in an interview like this, are those med students who forego residency
Yeah.
and are going straight into like pharma or whatever, maybe it's AI kind of stuff or whatever they're doing. And and what was it that what were they thinking when they applied to med school? Did something change during med school, or was it their plan all along to just get that degree because it mattered for whatever the fill in the blank is for that? I'm very curious about that because I think that's happening more and more now.
It is. And I think a subset of it is they become burned out in med school, which, med
Mm,
school is always hard, but they're actually having the burnout and they're looking to their residents that they're dealing with and they're burnt out. And they're looking to the physicians that are practicing and they're burnt out. And they're just thinking, you know, I haven't seen anyone really kind of plan it out. I've talked to several that in their senior year said, I just realized I just don't want to do patient care directly,
okay.
I usually tell them to go into public health because there's about half the people that work, get a public health, degree. And well, I guess it's preventive medicine and preventive, is a 2-year residency. A lot of them go into administrative right away. They don't really ever take care of patients. So, but but yeah, I think there are some now that are just looking at that. And, to me, a medical degree is the equivalent of a PhD, it's just a lot
Hmm.
broader and somewhat shallower in some ways, but you should be able to get a career that's pretty awesome, even just with the medical degree, if you plan it properly. But most the people I talk to typically they had to stop, they were forced to for some reason. Either they moved, to another
Mm,
country, or they some got sick, or they couldn't match on the residency, these things that are not necessarily voluntary. But I think you're right. There are some that go into it thinking, I'm not going to practice later for very long, if at all.
yeah, yeah. And some that are like, nope, that's not even part of the game. And
It's
then
kinda-
I wonder, well, if you're going into pharma or whatnot, how do you how can you be as effective as you think you will without
yeah, that's
seeing
true.
the diseases sort of evolve or seeing some of the the end stage stuff and what you're trying to prevent earlier and through medication or whatever it is that you're involved with, even detecting or using AI and they're like, yeah, I did med school, but not doing any clinical stuff. I don't know.
Yeah,
It baffles me a little bit.
yeah. I don't know. It's interesting. Oh well, I'm gonna let you get back to your day. Hopefully, I guess it's not work because I think you're not working today. So that's good. And get to the rest of your time off and vacation. I will keep you posted on when this is going to be released. It'll be, like second or third week in January, probably. And I'll
Okay.
send you the MP3 for, if you want to use it anyway. Anything else, anything I can do for you?
Not that I can think of. I Do you want to know about any of the if I get outreaches through LinkedIn and what kind of questions people have asked? Is that
Sure.
a set of information that you like to,
Yeah, that's
tag
useful
along?
for me because if you get like 3 or 4 questions on a similar topic, and it's something I could have either you come back or someone else address, as a common question of clinicians or med students or whoever is reaching out. Yeah, that's
Yeah.
always helpful to me. That'd be
Okay.
great.
Okay.
All right, but we'll keep in touch too. But you just have a great rest of your year, and again, I really appreciate you for sharing all your wisdom and experience with us. It's fantastic.
I'm happy to. I mean that I'm very happy where I am and I want, to help others sort of
Yeah.
get there on their pathway. So this was a pleasure. So I appreciate
All
it.
right. Thanks a lot, Nilesh. Take
Yep.
care.
Take care.
Bye bye.